and we'll hope to do something with them after the session today. So without further ado, I'll hand over to Melissa and Freya. Thank you.
Hi everyone, I'm Melissa Coe. This is Freya. This is Freya Tracey. We're both from the Health Foundation, and we're talking about uncertainty, politics, and analytics. And this is our experience of building projections of the elective care waiting list. So a bit of background that probably a lot of you already know, but as you probably know, elective care took a huge hit during the COVID-19 pandemic. A lot of procedures were stopped, and there was a huge backlog of people waiting for care post-pandemic. This has been a topic of political debate for a long time, as you can see. And in January 2023, the former Prime Minister pledged to make reducing the waiting list one of his key priorities before the next general election. So there was a lot of public debate about this at that time, around whether these targets could be made and how they would be, and how that could happen, and also particularly how much industrial action might factor into making these pledges. So obviously we now know that the waiting list hit a peak at almost 8 million in the autumn of last year, but that the waiting list continues to be an important issue for the new government to face. But what we want to do today is to take you back to August 2023, before we knew about the next general election coming up and what would happen to the waiting list. And we wanted to, in this piece of work, we wanted to understand what it would take to achieve the former Prime Minister's pledge and where we were at then across a range of possible scenarios. So as our title says, for this presentation, we want to spend a bit more time reflecting on what it's like conducting analyses at a fast pace in a highly political and uncertain environment, a little bit more than going really deep into our methods, which you can find on our actual report. So obviously, as analysts, we love when things are very clear, when you don't have to make any assumptions, and you feel like you can easily be objective. But of course, that's almost never the case, and you usually do need to make lots of assumptions, and there's a lot of uncertainty. We felt that this project, it was a particular example where these challenges were really brought out and under a lot of high scrutiny in a highly political environment. So we know that you probably also have examples of this on yourselves, so we'd like to invite any conversation and thoughts that you have as well.
So I'll give a summary of our work. So our report started with a description of how the waiting lists have changed over time and how this is informed by the changing referrals and the completed pathways. So the waiting list that we're talking about here is everyone in England who is waiting for consultant-led care, who's had a referral but hasn't yet started their treatment. And in very simple terms, to get the waiting list to shrink, you need more people coming off the waiting list, which are known as completed pathways, rather than people joining the waiting list, which is known as referrals. So at the time of our work, there was a lot of discussion around industrial action and whether this was affecting the likelihood of meeting the pledge to shrink the waiting list. So it was important that we gave some context to this and the impact that this might be having, as well as acknowledging what we couldn't cover in an analytical piece like this. So the longer term impacts beyond what appointments were missed on the day of a strike. We modelled 4 scenarios to show the range of what could happen between September 23 and the end of 2024, which was the last possible date for a general election. And this looked at whether hospital activity grew or stayed the same and what happened with strike activity. But with so much uncertainty around these parameters in particular, we also built an interactive calculator, and that allowed users to explore their own scenarios and see how much of a difference these parameters had on the waiting list, and also allow them a chance to see what it would actually take to get the waiting list to shrink. And the QR code will take you to our report. So this is what our waiting list interactive calculator looks like that we built in R Shiny. There's 2 graphs here. So the first graph shows the waiting list size with the dark purple, the historic data, and the light purple, what is modelled. And then the second graph shows the completed pathways and the referrals. And this influences the purple bars. So as I said, you need the completed pathway line to be higher than the referral line in order to get your purple bars to shrink over time. This will just take you through the different ways that users can use it. So if you click through the scenarios, you'll see that the graphs change, sometimes not by very much. So sometimes between our different scenarios, we really didn't see much of a difference in the waiting list projections. And then users also have the chance to change parameters, so they can change the referral rate or how many months the strike activity continues, really to get their own ideas about how different things will come into play. And all code is available for this on GitHub if anyone wants to look at that further. Is this going to stop playing? So moving on to the three things that we think we had to deal with a lot, starting with uncertainty. So the waiting list should just be a simple inflow-outflow model, but of course it's never going to be as easy as you want it to be. People leave the waiting list but without being recorded as a completed pathway, which was a weird quirk of the data, which we discussed with NHS England and they're aware of, but we had to account for it in our work, but using some assumptions. Along with this, we had to look at the impact of strikes. We didn't know, and no one else knew, and we still don't know what's going to happen with doctor strikes and how they're going to change over time. And particularly, we didn't know how they were going to change over winter pressures. And also, we didn't know how referrals would change. It was expected that they would increase after COVID as people were able to access GPs, but we didn't know whether more people were going to come forward than we had seen before. So the main way we dealt with this uncertainty was through this interactive calculator, because it allowed people to explore it rather than making lots of tight assumptions for people. And by having scenarios which changed just by one thing at a time, it allowed people the easy option to compare having strikes versus not having strikes continue. So we made these decisions, and now we had to put them into a model.
Yeah, so this is the part that probably a lot of us are more used to, which is making decisions in analytics. So part of this we wanted to figure out what we really need to prioritize in our analysis. And we felt that one important part of the task was to make this also kind of an explainer of the waiting list. So we really wanted to ensure that it was simple and explainable to non-analysts as well, including policymakers. So we suggested no sort of black box models or AI kind of things. We also knew that we wanted to ensure that it was reproducible, so that people could even look at it, challenge it based on how political this was at the time. And we needed to balance this quick turnaround time that we wanted in order to be able to influence policy right away, as well as trying to make sure that our model was still robust and accurate, and again explainable. So what we did to try and achieve this was to ensure that we were using publicly available data, which did result in our findings actually diverging from what, for example, NHS England would report, because we didn't have access to the same data sources and they had slightly different methodologies. Also, because of the quick turnaround time, we wanted to do this all within a month initially. We also settled on using a relatively simple model, which looked at linear growth of referrals and completed pathways per working day each month, with a seasonality multiplier for different months. So obviously, you would never expect the waiting list to actually grow in a straight line forever. But since we were trying to evaluate this on a very specific short-term deadline of by the next general election, which was within a little bit over a year, which we thought at the time, we thought a linear model was good enough for this kind of analysis. And we tried to make really clear in our report that the model wouldn't necessarily extend further forever. And then, of course, now that we had the model, we needed to disseminate this, and this is where a lot of the political part came in. And we felt very strongly that we had obligations as analysts, and obviously particularly as analysts for a charity, to remain politically neutral. But we also wanted to make sure that we were able to influence change for the better. So as Freya kind of talked about, industrial action wasn't actually our initial focus, and we wanted just to kind of understand what the waiting list looked like and what it might look like in the future. We ended up spending a lot of time actually thinking about the impact of strikes, because this was such a big talking point in the media and the political conversation that we wanted to make sure that we were doing something to answer some of these big questions, even that wasn't the original aim. We hope that, as Freya said again, the multiple scenarios and being able to have custom user input would help us avoid taking really hard stances as well. But we were aware that even things like the order in which we presented scenarios and the visuals we used in our wording could have an influence on the readers. So in the end, for example, we didn't find that strikes has as high an impact as other stakeholders found, such as in NHS England's own projections, which were based on other data and other methodologies. But we tried to ensure that all of our assumptions were backed with historical data, even if the methodologies were slightly different. So for example, with the strikes, looking at prior data on appointments and procedures in non-strike months, and then comparing them to how many completed pathways were completed during those months to see on average how many appointments or procedures convert to completed pathways. We also felt that it was important to have an ongoing discussion with NHS England and other stakeholders and other analysts to ensure that they were informed of the methods, and so that we could also sense check with them about whether they thought that these made sense.
So we made our models, we published them, and then we waited to see how these matched what the referrals, completed pathways, and the size of the waiting list looked like in reality. So on this graph, the dotted line shows the model period, and the solid red line shows the real data that has been reported by NHS England. So at first, the referrals were looking very similar to the modelling, but now we're seeing referrals are lower than expected. We're not sure why this is, and it's not necessarily a good thing because it might be influenced by people's ability to access a GP referring behaviour, or how hospitals are accepting referrals. When we look at completed pathways, we see that completed pathways have looked more similar to what we modelled, but they're still slightly lower. But the main good news story here is that they are higher than what we saw pre-pandemic. So whilst the waiting list is shrinking very slightly, this is more a product of fewer referrals rather than more pathways. So I think there's some kind of cautiousness that we need to think about as we go forward looking at this.
Okay, I'm just going to wrap up really quickly. Obviously, waiting list is going to be a continued political focus for the new government. It's going to take a really long time, probably still, to see a reduction in the waiting list to pre-pandemic levels because of the backlog. But it's important for us to continue conversation around things like industrial action and ensure that we're fairly representing both the people who have been impacted because their care has been disrupted, as well as those who are striking. Possible future work that we might come up or that we suggest would be useful is understanding why this referral trend is on a downward trend, or not on a downward trend, but reduced as compared to what we would have expected. Doing more longer term projections, as I said, with slightly different modeling approaches that might not just be drawing a line out quite far. And also looking into different regional inequalities or differences by particular elective care specialties. And very quickly, before we wrap up, just to plug some of our other colleagues' work that are related to the elective care waiting list, as well as some QR codes where you can access the report again, and a more recent blog that Freya discussed on updating basically what happened with our projections. Thanks so much.
Thank you. That was an amazing job in 10 minutes. Thank you so much. We do have a few questions. We're probably not going to get through all of them, so apologies to some of you. Bianca, do you want to read them out?
First of all, can everyone hear me?
Shall I do this?
Thank you. Did you take any account of demand due to backlog of follow-up care for patients already completed their RTT pathways?
No, so we only looked at the RTT data. So there are people who will complete, and so the RTT data is the referral to treatment data, and that reports someone going from a referral to the start of their treatment. Some people will continue, once they start their treatment, they might then continue waiting, but they won't be captured within that data set. So I think that's what that question is about, but we didn't include them.
Do you plan to revisit this with the new policy and intention of the new government?
I think that's kind of up for debate. I think that was one of our kind of what we might want to look at in the future. I think the waiting list is going to continue to be a big topic, so there's a good chance we might look at it, but also welcome other people to look at it as well.
Yeah.
What was the difference between your data and the data used by NHS England that caused such differences?
The NHS England had, So I think it was more around the specific methodologies, in particular looking at the effect of strikes, where the way that we looked at it was kind of by creating a sort of conversion rate for how much we thought that like canceled appointments and canceled procedures would result in completed pathways not being completed. Whereas I'm not sure of the like full, I don't want to misrepresent the methodology, but I know that it was more around like different methodologies and slightly different data used, especially because we were only trying to use public data. Not to say that one is better than the other or anything, but just to say that we were hoping to be like quite transparent so that people could then read it, look at it, and kind of think through themselves what the differences are and why they might be there.
Do you have any thoughts on areas where data science can help achieve these scenarios, e.g. help improve growth?
Can you repeat the question? Sorry.
Sure. Do you have any thoughts on areas where data science can help achieve these scenarios, e.g. help improve growth?
Data science?
Yeah. I mean, I think we'd all agree here that data science is key to helping the NHS improve, but I don't know if there's a particular way. I mean, there's so much work on NHS productivity, which will be fueled by data science, and hopefully will be fueled by data science rather. But I think it is a huge thing to sort out, and I don't think there's one bit.
Yeah, there's always, of course, there's sort of like us trying to evaluate waiting lists, and there's also like the people who are putting things into production to try and figure out like how we can make things more efficient. But yeah, I guess it's quite a general answer.
Okay, try and go on to the next one. What impact did you see on policy from your model? If none, what impact were you hoping for, expecting, if the GE had happened later?
I think we saw a lot of impact from our work. We saw really good responses from organisations like the BMA and NHS Confed, and it was spoken about a lot. It did get picked up a lot in the conversation around industrial action at the time last October, and then in the build-up to the election now, or that just happened, our work continued to be quoted around the impact on industrial action. In terms of policy, I think it was kind of a moving situation, and Rishi Sunak took back that pledge about shrinking the waiting list. I think that was
Not necessarily directly because of us.
yeah, I'm not, there is no causality. I want to make that incredibly clear. It's time for me to get off this stage. But there was, I think it was received well, and I think it did feel like it contributed to conversation. I don't know whether we can kind of pin a single policy decision on it.
Yeah, I think understanding too that there was sort of like ongoing like sort of chronic underfunding, chronic under-resourcing issues in the NHS that are kind of maybe more prevalent as compared to things that are a little bit more short-term, like industrial action, kind of hoping to kind of focus some of the like policy making on that kind of resolving those issues, those like big longer-term issues as well.
I think we're out of time for questions, but thank you so much. So